Have you ever had pain on the outside of your hip? Or maybe you saw a patient who complained of this pain? Either way, it can be very challenging to deal with sometimes. In this video, we're going to talk all about greater trochanteric pain syndrome, so let's dive in. Welcome back, team, to the Building Lifelong Athletes podcast. Thanks so much for stopping by. I really appreciate it. For those of you who haven't met me yet, my name is Jordan Rennicke, and I'm a dual board certified physician in family and sports medicine. And the goal of this podcast is to help keep you active and healthy for life through actionable, evidence-informed education. Today, we're talking all about lateral hip pain, or otherwise known as greater trochanteric pain syndrome or gluteal tendinopathy. They're all kind of the same. We're going to talk about what it is, how to diagnose it, and how it's treated. So let's get started. All right, so let's dive in first to why this matters and why we care about this. On average, about 23.5 women over the age of 40 will experience this at some point. So almost a quarter of women over 40, whereas there's only about 8.5% of men between the ages of 50 and 79. So as you can see, does affect women more than men on average. And if it does affect men, typically a little bit older. But this is actually the most common of all lower limb tendinopathies, which is actually kind of surprising. I would have figured either Achilles or maybe patellar tendinopathy would be the case, but no, it seems like this greater trochanteric pain syndrome is the most common lower limb tendinopathies. And they even had one study that mentioned that disability levels from this can be equal or similar to those with end-stage arthritis. And so this really hurts and can affect people's lives, right? That's the biggest thing. People come into clinic and they do not like this. It can be debilitating at times. And so we care so much about this because it's affecting people and what they can do. So that's number one, why we care about it. If we go into anatomy here, I want to dive in first. We always start with anatomy. The greater trochanter, this is kind of a major location on the femur, right? So if you look down here on the video version here, you can see kind of this bump, and this is our greater trochanter of the femur. And there's a lot of different tendons attaching around there. We have our external rotators, which are the superior gemellus, obturator internus, inferior gemellus, piriformis, quadratus femoris, right? So just think there's a bunch of them. That's the big thing. Those attacked in the trochanteric fossa, so kind of around this area, not necessarily on the greater trochanter, but in that area. And I just want to mention all those by name, not because I expect anyone to know those or remember them, but just understanding that there's a lot going on in the posterior hip that kind of wrap around and attach to the side. There's a lot more than just the piriformis. Most people think like, oh, it's the piriformis, there's something going on. No, there's a lot going back there. But those attach into the trochanteric fossa, which is nearby the greater trochanter. And then the gluteus medius and the minimus, which are the abductors of our hip, those attach to the greater trochanter. And then we have bursa usually between the glute muscles and the IT band. And the IT band lays on top of all of it. So this kind of diagram here, looking at the video, is we can see all these muscles coming down here. These here are our glute min and glute medius. These are the ones that attach on the greater trochanter and responsible for hip abduction or bringing the leg up to the side. And then on top of them, we kind of see here, this is the tensor fasciae lata and the glute maximus come here and then attaching this IT band, and the vastus lateralis is here as well, because the vastus lateralis, glute maximus, and tensor fasciae lata all insert onto the IT band as well. So they are responsible for creating kind of some tension on the IT band. And then you can see here, they actually go over and slide over this greater trochanter. So this is important because they can cause friction there, that essentially there. We can cause compression. And so that's really important for understanding the pathophysiology behind this condition, but understanding there's a whole lot going on here. But going from this, we've got the pelvis going on to the greater trochanter. These are our gluteus minimus and medius. That's the big takeaway. And then on top of that, we got additional stuff that can kind of push into it. So that's what we think about there from an anatomy perspective. If we think about pathophysiology and old ideas, I mentioned this because most clinicians have an outdated view on this. I shouldn't say most, but most in primary care do. Once upon a time, everyone learned that this was trochanteric bursitis, right? Hey, it's angry. The bursa is angry. It's all inflammation, right? Not surprisingly, this is not the case, because as we're learning more about tendinopathies, which we've talked about previously, tendinopathies in general aren't really inflammation. And we have that short, acute, possibly inflammatory stage, but it's usually not the case. And by the time they're seeing you, it's been multiple weeks, and probably it's more into that degenerative type condition. So the big news here, it's just like any other tendinopathy. It's not necessarily inflammatory. And we think this is due to a gluteal tendinopathy specifically. So we talked about the gluteals. Those are kind of coming down from the pelvis, attaching onto the greater trochanter. We think it's a tendinopathy there, and that's probably why. And the million-dollar question is why? Well, we think it's probably due to overuse or a spike in activity, but we may also have some compressive forces playing a factor. Like I mentioned, I wanted to talk about all those different structures, the IT band and the TFL and whatnot, going over the greater trochanter, because those can cause issues with this condition. It may be one or two things. Kind of think about it is, overload, meaning, hey, they've just done too much. Someone's like, I'm gonna start running. It's time for a marathon. And then that's a pretty classic story of, hey, I'm trying to, lose weight or do something, and then just spike up their activity. And that's just a little too much. And we know that tendons like the perfect amount of load. And then, or maybe they also had compressive stuff on that. And we'll talk about what kind of makes that angry for people, but those are kind of the two main ideas we think about. And now what we kind of say is just the overall term is greater trochanteric pain syndrome, or we can call it gluteal tendinopathy. I've heard both of those things. Those are kind of the new terminologies. No longer calling it ischial bursitis. If you call it ischial bursitis, I will say most likely not. And I do want to mention that it doesn't mean you can't have a bursitis, right? I'm not saying that doesn't exist, but the vast majority of the time we look at it, it's not that. So I do want to look at this kind of chart here. I thought it was really interesting, showing about what happens with tendons, right? So when we get forces on tendons, what happens to them? And there are multiple forces that can happen. First of all, compression. When you think about compression, this is when we're talking about on that greater trochanter, we have the musculature kind of compressing into it. And they say transverse, meaning going this way, not longitudinally with the tendon fibers. So kind of the tendon fibers are going up and down. This is coming in from the side. So that's compression. That's usually catabolic to the tendon. They don't like that. It kind of makes it angry and it can lead to reduced tensile strength. If we have tension, which is in that longitudinal plane, meaning, hey, it's going in line, that can be catabolic or anabolic depending on the load. And once again, this is just general tendinopathy talk is what I'm talking here, but it's kind of just important to think about. If they have a less than normal load, meaning we're not doing much, that's also catabolic. So as I mentioned, tendons like load. It's like Goldilocks, though. You got to find the right amount of load for them. If you have normal, regular load, that hopefully we have, catabolism equals anabolism, meaning we have homeostasis there. It's just kind of being happy. And then if we have slightly greater than normal load, usually that's anabolic. We are having increased tensile strength. So essentially slightly greater than normal load is how we make gains in everything, right? In rehab, in the gym, how we get stronger, all those things, we just incrementally go up, but it's in a safe and controlled way where we're not spiking up too much. And then the last one here, talking about a much greater than normal load, that usually leads to a catabolic issue and we have failure to adapt, and then we start getting tendinopathy. So the takeaway from this chart I just want to mention is there are multiple forces on a tendon, and we have to consider what load and forces are being put on our tendons that could be causing the underlying tendinopathy. And the greater trochanteric pain syndrome, or the gluteal tendinopathy, is no different. And that's why I just wanted to mention that there. I thought it was kind of cool, nice little chart to kind of talk about. But if we move on here, after we talk about the pathophys there, we can kind of go into the risk factors. And there are multiple risk factors. As I mentioned before, there's kind of two categories of these people. Usually it's either in sedentary patients who are a little bit older or like runners. And specifically, usually age, women over the 40 have the highest numbers. Sex being female does seem to confer a risk factor for that. Elevated BMI may also be a risk factor. And then also hip possession may impact that as well. Meaning if you're in more adducted positions, we're having more compression on that. So if you think about it for a second, if our hips are out here, and when we adduct, we are bringing our legs in, right? And if you think about if you're doing that more consistently, that lateral hip might be getting more compressed by the IT band or what the other structures out there. And so if we're doing this more, that might happen. Things that happen to do that are like leg crossing, like crossing your legs. We call lateral pelvic tilt. If you're shifting during running, if you're kind of going side to side and you're not kind of going in a straight line, that may happen. And then also if you have just abnormal hip anatomy, meaning you maybe have a wider hip. Here I'm going to show up a picture right here. If you have something called coxa, which is a decreased femoral neck to shaft angle, that also increases the risk. It's essentially leading to a wider hip, wider greater trochanter, and it's more compression. As you can see here, someone with coxa on the left side of the image here kind of has a wider one, right? And it's just like when you're out there wider, you just got to go along further, and so we're going to have more compression, whereas on the right side is the kind of normal angle. And so if we kind of have those wider greater trochanters just by anatomy, that can also be a risk factor as well. And so multiple risk factors. The big things I want to think about, predominantly going to see this in people who are usually like peri, or postmenopausal females, because female and age can be a risk factor. At that time, the hormones are changing. That also may be a risk factor. Listening to some podcasts talk about that and reading some articles how as we age, estrogen may play a role in tendon health. And so as we age in females, that may lead to more tendinopathies. So just kind of an interesting thing to think about there, but we get more there. But then we also have the runners who are just like, yeah, I run all the time, and just lots of steps. And that's when we talk about maybe just thousands and thousands of mini steps with their hips kind of, or they're kind of crossing their body a little bit, leading to more friction. Some things to think about, or it just might be overload. So lots of different things. I want to real quick talk about our presentation. Usually this is an insidious onset, right? This should not be an acute injury. If there's an acute injury, it's probably not a tendinopathy. That's usually it. You could think about a tear, but that'd be super rare necessarily. These patients will present with pain on the lateral hip with or without radiation down the lateral thigh. So that is one thing people will say, like lateral hip, but occasionally they say, yeah, it goes down the side of my leg. And that is a relatively common complaint to this. So it's just something to look for. It doesn't necessarily mean that there's necessarily nerve involvement, but you can see that. A lot of times these patients have pain with sleeping. They say, when I sleep on it, it really hurts. And they may have pain with one-legged tasks, like walking, going upstairs, balancing on one leg to get dressed. So you're trying to put on shoes, something like that. Maybe their history says there's some recent increase in activity. And as I mentioned before, maybe postmenopausal. So hormones may play a factor in that. And so from a presentation standpoint, like if you had to memorize one thing, it's usually like kind of just came out of the blue just randomly in terms of like, yeah, I guess I had it. There's no like one moment. It just says, oh yeah, like I guess I've been dealing with this. I felt a little bit and then it's kind of gotten worse. That's usually what we think about it. Usually it's repetition based, like increasing, and then also may have certain risk factors as well. Like I mentioned, perimenopausal, a lot of times that may cause some issues as well. But the presentation, that's typically what it is. I'm going to say my outside of my hip hurts and it's going to come on chronically. So going to our physical exam, how do we diagnose this? Well, the big thing is first we're going to start off with palpation, right? So you're going to palpate that greater trochanter. This has a high sensitivity, meaning it's very good at ruling out this greater trochanteric pain syndrome, but can't be the only one to rule anything in. So when I say high sensitivity, what it means is, hey, if this test is negative, I push on you, you do not have pain, then the odds of you having this gluteal tendinopathy or greater trochanteric pain syndrome are not very good. And so this is kind of that one. Obviously, can you still do it? Yeah, like everything, there's no perfect test, but if I'm just really pushing on someone's greater trochanter and they say, no, they have no pain, it definitely gets you thinking, like, is this actually coming from that greater trochanteric area or is there something else going on? Another thing we can do is we can put patients into a single leg stance. Essentially, the patient stands on their affected side for about 30 seconds. And if they reproduce their pain, then it's a positive test. And this test is a highly specific test. So specific means it kind of rules in, meaning, hey, if you have this, then there's a high probability that you actually have greater trochanteric pain syndrome. So really right there, we have a really good combo of tests. Palpation is highly sensitive, and then single leg stance is a little bit, it's not a fantastic test, but it's more specific and that can be helpful. So right there, like in primary care, those are two really big ones. And then another test we can talk is the Faber test. So we get the hip into flexion, abduction, and external rotation. This is a very non-specific test. So this is not one that says, oh yeah, like this qualifies for it. But what this does, when we get in that externally rotated position of the hip, sometimes that can lead to compression on the outside of the hip. So when we get in that external rotation, maybe leading to some compression, maybe reproducing some symptoms at the greater trochanter. That's kind of what we're looking for there. Faber is usually part of any hip exam, and so it's worthwhile doing. On top of that, we also have the Fader test. So that's not to be confused with the Fader test, which you should still be doing a Fader test on any hip to make sure we're ruling out intra-articular pathology. But there's this test in the literature they talk about as Fader, where essentially getting that flexion, adduction, so adduction coming in with external rotation. So once again, flexion, adduction, and then you externally rotate the leg. And there's a Fader resistance test as well, or Fader R, where you get that same position as the Fader, but now you resist internal range of motion. The idea behind that is that when you're doing this and they're in that kind of cross-body position, we're putting compression on there. And then when we instantly rotate, we're just making it a little harder as well and compressing a little more and putting tension on those internal rotators, which is kind of putting them on stretch, the external rotator. So the idea is that you put them in that bias position of adduction, and that's kind of what it is. And then the next test we can talk about are you bias them again, once again, in the adducted position. Essentially, it's like an Ober test. An Ober test is where we essentially had someone laying on their side and, get your hips in neutral, and then you bring the top leg down and passively adduct it so it gets to the floor or to the table or whatnot. And then here you can also add additional pressure on to kind of give an overstretch. So that's like the Ober. People used to think it's for testing for IT band tightness, which it's really not a great test for that, but it does put us in that adducted position and may lead us to compression irritation on the lateral hip. So it can be helpful. And once again, we can just add on resistance to that. So the add R test, this is essentially the Ober test again, laying inside passive adduction, and then you bring the knee, to the table or floor, and then you resist abduction. So you're pushing up and trying to abduct the hip to try to activate those abductors, right? Which are the glute min and glute med, and you're still kind of testing this. So there's a whole lot of tests there. As you can see, what I usually say is when there's a whole lot of tests, that means like no one test is great. It's the same thing for any other joint in your body. We do a bunch of them to try to confirm things, right? So if you have multiple tests that are positive, you start to think, okay, cool. This is giving me a little more detail of where this might be. And so that I don't want to overcomplicate things. I think if you're in primary care and you're like, yeah, I'm not doing all those. That's very fair. Any hip exam has to have the Fader, right? We got to do the Fader to rule out intra-articular pathology. But then on top of that, if I had to pick, palpation, huge one, and then get them in their single leg stance. That will tell a lot of things. Those are kind of the big ones. And then usually Faber is a part of that as well. But if you just did the Faber, single leg stance, palpation, and Fader, I think you'll be good in terms of primary care exams. But there's a lot going on there. And this is why understanding the mechanism is really helpful, right? If you think about trying to compress that and tension, that's why getting into adduction can be helpful. We think that lots of excessive adduction leads to that compression irritation. And so putting them back in that position is a good way to bias it to say, hey, let's see if we can stir this up. And if we can't stir it up with that, then we think maybe it's not coming from the greater trochanter area. Maybe it's something else. So that's the general physical exam. I don't want to get you bogged down too much there, but overall, there's some cool ones that we can do, but for the primary care, we can keep it really simple. Moving on to imaging and making the diagnosis. Imaging is not needed to make the diagnosis. This is going to be a clinical diagnosis for the vast majority of people. And on top of that, imaging, X-ray, we kind of use that to rule out things like osteoarthritis, but it's not going to be super helpful to rule in greater trochanteric pain syndrome. What I mean by that is, if this is a tendon issue, it's not going to show up very well on X-ray, right? X-ray is us, if we think we can't tell, like, is this, arthritis? Is it not? Absolutely. We should be getting an X-ray to make sure we're not missing arthritis if that's on your differential. But it's not going to show an issue with the tendon unless there's calcium there. You can have something called calcific tendinopathy where we have calcium deposition inside the tendons. That would be an indicator though that is a gluteal tendinopathy. So I see calcium in a tendon, I think that's an angry tendon, and I essentially treat it like a tendinopathy. There's different treatments. You can do things like a barbotage where you go in there with a needle and essentially break up the calcium. It sounds barbaric, but we put lidocaine in there, so it's not too bad. But you can do that and break it up. That is a possibility. But X-ray overall, just kind of ruling things out. You can use ultrasound as well. That may see calcium deposits, may see an enlarged bursa. Maybe you'll see a thickened tendon as well. A lot of times for ultrasound, for like Achilles and whatnot, we can see thickening in the tendon. For this, it's not as great looking for the tendon itself because it's deep and the probe isn't quite as detailed. It's a little more challenging, but we can definitely do it. And then the gold standard, quote unquote gold standard, not needed by any means, is the MRI, where it's kind of used to rule out other things, right? If you're worried about anything intra-articularly, you can use this. You may see a signal inside the gluteal tendons to confirm the diagnosis, but it's not needed. And when I say gold standard, I mean it's gold standard for like research studies, right? So they'll do the tests that, they think they're provoking things and say, hey, does this actually correlate? So what they'll do is they'll kind of test the test to see if they actually, test for what we're looking for. So they'll do like a study I looked at here. They were talking about all those different tests I talked about, like the one leg test and the, again, adduction, resistance, all that stuff. And they said, okay, they check those in patients and then they get MRIs to see if there's a signal there. And, the MRI is just kind of to guide it. Most of the time you do not need to get an MRI. Honestly, if someone comes in, gives you an insidious history of this, there's pain there, pain with single leg stance, maybe pain with one other test, it's a pretty slam dunk clinical diagnosis to at least start, right? Common things being common, it's most likely that. There's other stuff we can think about and we have to keep our brains open, but that's kind of what I think about is we do not need imaging necessarily. If you're worried about intra-articular, absolutely just get some x-rays to make sure, but not something we totally need. And when we're talking about differential diagnosis as well, we talk about things that could be, we want to make sure we're not missing things like intra-articular pathology, meaning femoral acetabular impingement, osteoarthritis, maybe a labral injury. And on top of that, referred pain from the back is a very common one. So the hip is very complicated. There's a lot of stuff going on. You can have referred back pain. So if you have back pain, you could have, nerve pain kind of coming down into the posterior hip or lateral hip. That could be what's going on. And so there's other things that could cause it. But that's kind of what we think about. And when we're talking about greater trochanteric pain syndrome, what this is including is things like gluteal tendinopathy, small gluteal tears, so actually smaller tears as well, trochanteric bursitis, IT band friction there. So it covers a whole bunch of things in that area. And so from a differential wise, it kind of lumps them together. And as we've talked about many times in sports medicine, that's kind of what we're doing, whether it's rotator cuff related pain or now greater trochanteric pain syndrome. We're saying, hey, we don't know if it makes a difference if we definitively know where this is coming from, but we know it's kind of this constellation of symptoms. And so that's just something to think about there. And then moving on here, talking about our treatment. In our treatment, we treat this like a tendinopathy, right? So I know I'm kind of beating a dead horse here, but tendons like load. That's like the thing I say all the time. And people probably hate me for saying that. My learners are like, okay, yeah, I get it. But tendons like load, right? But it's that Goldilocks principle. We need to find that right amount. And so when we're treating patients here, we start off with activity modification and then followed by progressive loading. So the idea is to initially right away, we want to reduce painful activities in terms of like maybe not doing as many steps or hill walking or crossing our legs and then increase things from there. And one idea is if someone's, all the time they sit with their legs crossed, like cool, we can do exercises, but like if we're not stopping the inciting thing, then we're going to have issues. So sometimes early when it's really reactive or angry, the goal is to, okay, like what are we looking at here? Are you crossing your legs all the time? Are you standing with your hip kind of just like plugged to the side? Some people when they're standing, they don't stand nice and upright. And not that I want you to think about posture all the time, but if you have this and you find yourself just leaning to one side, that may be a risk factor. Maybe you're crossing your legs while you sleep. Maybe you sleep on that side. All these things we can think about like adjusting, like can we sleep on the other side? Do we need to have a pillow between our knees so that our hips are a little more neutral, not an adduction? Do we need to not cross our legs when watching television? It sounds really stupid, but these are things where if we can just stop the inciting, event, we can maybe calm things down a little bit. And then we start getting into progressive loading where, which is really important. And that's like the biggest thing here is getting into a loading program. Stretching is something they typically recommend against. So a lot of times people think, they do the pigeon stretch for yoga, like, I want to stretch my hip, that feels good. But once again, if those are the positions that are provocative, like the cross body stuff, adduction, then we're doing probably more harm than good by continuing to just try to stretch that out. And so also foam rolling, we don't want to just be foam rolling over the greater trochanter. It's once again more compression, so that's not what we're going for. So stretching is not like a main component of this. It's really going to be strengthening and rehab. From an injection standpoint, we talk about steroids, question mark, I said, absolutely not. I don't think we should be doing that. This used to be the answer for everything. Like literally, I remember even in medical school, so not too long ago, although I'm getting kind of old, but in medical school, I'd go to ortho and they just line people up and they just boom, 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 inject it. See you again in a couple months. And that's outdated now and pretty much should not be routinely done. I've seen multiple older women now come in with complete rupture of their gluteal tendons that required surgery because they just had repeated injections over and over. We know that steroids are not benign. We know they weaken tendons and the tenocytes. They're not good for long-term tendon health. And so that is not what we're looking for. It is definitely good for immediate pain reduction. But overall, at about 12 months, there doesn't seem to be any benefit or difference between injection and not injecting that. And also what it leads to is a high rate of recurrence. So people get these injections and they're like, great, I feel awesome. They come back in a couple months and they keep doing this over and over. And it's a vicious cycle. So if you are working with someone or you see someone and they recommend, doing a hip injection, a steroid, I would probably pass this for mine. A lot of times people have to get multiple injections as well. And then it leads to longer recovery and it's just not fantastic. But obviously there's a time and place for everything, right? I'm not anti-injection. If someone's in awful pain, terrible, they have a big event. I've definitely done this multiple times where someone's like, I have this big, huge vacation or this cruise or whatever. And like, I can't walk. And like, I just want to enjoy this. It's a once in a lifetime experience. Like, yeah, like I'm a human being and we can talk about it and figure that out. But I don't want you to just carelessly think about, hey, we're going to do injections no matter what, because that's what used to be. It's a bursitis. So you're probably not a bursitis and tendons don't necessarily need to have injections. So just wanted you to think about that. From a prolotherapy or PRP perspective, we've talked about it before, but prolotherapy is going to be dextrose prolotherapy. And there's not a lot of great data on that or PRP, platelet-rich plasma, but can be an option if you've failed other conservative treatments. But as I mentioned before, the injections aren't fixing the underlying problem with the tendon, right? It's more kind of for pain modification. I think of these injections as kind of like a reset button. You're injecting various substrates into and around the tendon. It kind of resets things, kind of decreases pain sensitization. And my goal is by doing that, you're able to like tolerate load better because that's ultimately what we need. So injections are always kind of a bridge to get you to do what you need to do from a tendon perspective. So that is an option. You can try that. They've also mentioned shockwave therapy. There's some mixed results, maybe some positive, probably less invasive than injections, but hard to find and also not fantastic results. And once again, not really changing the underlying pathology of what's going on in the tendon, but once again can kind of decrease that pain potentially to help you tolerate things better. And last resort is going to be surgery, rarely needed. Either it's a repair of the tendon if there's a tear or removal of the trochanteric bursa. But I think most people are advocating that they don't want to do that. And most orthopedic surgeons that I talk to say this is not one they routinely want to do. Success rates are not fantastic. And so we always want to just consider that. But overall, to kind of get the summary here, this is a very common diagnosis. Typically, it's going to be someone like an older woman that you'll see. It's coming from an insidious onset. There's lateral hip pain on the outside there. You'll have pain with palpation, maybe pain with single leg activities that stress the gluteals or things that bring the leg over across into adduction. You may also have pain with kind of that single leg stance or, it's kind of the Fader test we're talking about in terms of adduction, external rotation, or just stressing it there. Essentially, we treat this like a tendinopathy with rehab and progressive loading. And please don't inject steroids. That's kind of my takeaway from this one. But overall, that's kind of where we're at in terms of I don't want you to go crazy and think that, okay, I need to inject people. That's like my big thing. So that's kind of the takeaway there. Hopefully this was helpful and you feel more comfortable with this. And overall, this concludes the podcast. Thank you so much for stopping by. I really do appreciate it. I hope you found today's episode helpful. And if you did, it would mean the world to me if you either left a 5-star review on your podcast platform of choice or you share it with a friend who you may think enjoy this. That would mean a lot to me. And if you never want to miss any content, consider signing up for my mailing list where I link that down in the description below. I'll send out the content I release during the week. And I promise to never spam you because I hate spam just as much as you do, but it's a way to kind of stay updated, make sure you don't miss anything. And so that's it for today. So get off your phone, go be active, have a great rest of your day. We'll see you next time.